Hello everybody, this is chapter 8 on joints. This is going to be the last chapter before our next exam. Our next exam will be on 6, 7, and 8, the bones and joints. Alright, let's go. Okay, so joints are also called articulations, the sites where two or more bones meet. The function of them are to give mobility and to hold the skeleton together. And there are fibrous, cartilaginous, and synovial joints. Now, the movements are either synarthrosis, which is immovable, amphiarthrosis, which is slightly movable, or diarthrosis, which is freely movable. Okay, so let's start with fibrous joints. These are connected by dense fibrous connective tissue. There's no joint cavity. This is synarthrosis. So it's complete rigidity, interlocking of bones. In this case, we're looking at the sutures and the cranial plates. So syndesmosis is the bones connected by ligament. Bands of fibrous tissue, and then you have, well, in addition to sutures, we've got syndesmosis and gomphosis. Gomphosis is the tooth socket, pagan socket joints. The fibrous connection is the periodontal ligament. Okay. Next, let's see, we've got a couple pictures of this. So, in the cartilaginous joints, like the fibrous joints, there's no joint activity, and it's not highly movable. So we've got synchondrosis, which looks at the joint between the cartilage joint between two bones. We've also got the epiphyseal plate, where we've got the hyaline cartilage. So this is a joint; it doesn't move. And then we've got the symphysis, like the pubic symphysis, this fibrocartilage holding together the two os coxae from the hip. And we've also got fibrocartilage discs in the vertebral column. So we see the fibrocartilaginous intervertebral disc right here. So there's not a lot of movement on these cartilaginous joints. Okay, synovial joints, these are fluid-filled. They're all diarthrotic, which means they're freely movable, and it includes almost all limbs. And so there are a number of features, but there are bursae, which are little balloons that absorb shock, and there are tendon sheaths. Let's see, there are 6 general features of synovial joints. They contain articular cartilage. There's a joint cavity that's fluid-filled. There's a capsule, cartilage capsule, which is pretty thick. There's an external fibrous capsule and an internal synovial membrane. Then there's a synovial fluid, which is very viscous and very slippery, which lubricates the joints. It also contains phagocytic cells to remove debris and invaders. And a couple different kinds of ligaments. There are capsular reinforcing ligaments, extracapsular, and intracapsular. Okay, so other features of these synovial joints are fatty pads, which are these cushions between the fibrous layer of the capsule and the synovial membrane or bone. And then there's an articular disc, or the menisci. And so here we've got a good picture of the articular capsule, the fibrous layer, and the synovial membrane. And so here we've got our joint with the synovial fluid, and then our ligaments holding the bones together. So there are bursae and tendon sheaths. Mentioned a little bit about this, but the bursa are little balloons, and so here's a subacromial bursa, so right below the scapula acromium. And let's see, that's the only bursa we have here. So the purpose of the bursa are to reduce friction where ligaments are present, muscles, skin. So whenever something rubs together, there, a bursa will be present to reduce that friction. And then there are tendon sheaths, which are elongated bursa wrapped completely around the tendons, and this is an area that will be subject to friction. Ball and socket is a common location for these tendon sheaths. So these are elongated bursa. Okay, just a closer picture of the subacromial bursa. So the stability of the synovial joint has a few factors. The first one is the shape of the articular surface. So a shallow surface would be less stable than a ball and socket. There's also ligaments. The more ligaments, the stronger the joint. Muscle tone. The more muscle tone, the more stable the joint will be. Let's take a look at this table. Structural and functional characteristic of body joints. Okay, a lot of detail here. I'd say it's worth looking, especially categorizing the different joints as synarthrotic, diarthrotic. So it's worth looking at this a little bit more. Okay. So let's see. We've got another figure. Let's skip it. Okay. So the movements allowed by synovial joints. First of all, there's an origin and an insertion. So all the muscles that attach to bone or connective tissue have an origin or an insertion. So the origin is the attachment to the immovable bone, where the insertion is the attachment to the movable bone. And we'll have more of this in chapter 9 and 10. So muscle contraction causes insertion to move towards the origin, which I should get a picture of that. But there's different ranges of motion of synovial joint. There's non-axial, which is slipping movements, uniaxial, which is one plane, biaxial, two planes, and multiaxial, 3 planes or more. Okay, and there are various movements like gliding, angular movements, and rotation. Let's take a look at this synovial joint in the wrist, looking at the flat bones gliding. Example would be these intercarpal joints, intertarsal joints. So moving the hand medial and lateral results in gliding motion. So there's angular motion as well, and so the synovial joint in your neck, extension would be when your head is back, flexion would be when your head is forward, and the same thing with your hip joint. You would have extension when you're facing the back, and when you're facing forward, leaning forward, you've got flexion. Now, hyperextension will be movement beyond the anatomical position. Usually would involve some kind of pain. Okay, so the movements allowed by synovial joints. There's flexion with your glenohumeral joint of the shoulder, which is raising the arm up, and extension, putting the arm back behind your body. There's flexion, raising your leg up towards your buttocks, and extension, straightening your leg. Okay, a few more movements. Abduction is away from the midline. Okay, so abduct is when you move something away from the midline. Adduction is when you move it towards the midline. Circumduction is a circular movement. It involves flexion, abduction, extension, adduction, kind of all of them in one motion. So circumduction is when you kind of circle that joint. And then we've got rotation. We've got lateral and medial rotation. So lateral rotation would be outward. Medial rotation you can do with your hip, inward. Also, there's pronation and supination. Okay, so when you're in the anatomical position and you put your, where are you? Here we are. You put your palms down, you're pronating. When you put them up, you're supinating. Okay, some special movements also. This is the ankle joint. We've got inversion, which is when your foot is flexed into the plane of the body, and then eversion when your foot is flexed out. There's dorsiflexion when you're pointing your toes up, and plantar flexion when you're pointing your toes down. How about one for the jaw? There's protraction when you push your jaw out, retraction when you pull your jaw in. Okay, elevation and depression of the mandible. It's another movement, as well as a unique movement with the fingers opposition. So here's a little figure showing the angular movements, flexion, extension, abduction away, adduction toward, circumduction, as well as medial and lateral rotation. Okay, so the types of synovial joints. There are various types. There's plane, hinge, pivot, condylar, saddle, and ball and socket. And so we'll go through each one of these, starting with plane. This is like seen in the carpals, where you have flat surfaces that articulate, and you have gliding movement. It's non-axial, okay? And we'll talk more about axial in just a second. Okay, so hinge joints are how they sound. They're like a hinge in a door. The example would be the elbow or the interphalangeal joints. So there's movement about a hinge, medial and lateral axis, and it allows for flexion and extension. Pivot joints, like the radioulnar joint, the pivot joints allow uniaxial movement, so on one axis, so let's say the vertical axis. Condylar joints allow biaxial movement, so we've got medial lateral axis and an anterior posterior axis, which allows for flexion and extension, as well as adduction and abduction. We can see these in the metacarpal phalangeal joints of the wrist and the knuckle. Saddle joints, they kind of look like a saddle you put on a horse. These are biaxial movements, so they allow adduction and abduction, as well as flexion and extension. So these are, this is something you could see in the carpals and metacarpals. And then finally, ball and socket. These are much larger joints. They are multi-axial movement, which means you can have flexion and extension, adduction and abduction, as well as rotation. And the glenohumeral joint of the humerus and the scapula ball and socket is a good example. Okay, so other synovial joints that are kind of difficult to characterize, there's the temporomandibular joint, which is the jaw. So temporal lobe, mandibular, mandible joint, so it's where the mandible and the temporal bone articulate. So it's a modified hinge joint. The condyle on the mandible articulates with the temporal bone. To stabilize this joint, there are a number of ligaments, lateral ligaments, that hold the joint together. A little bit more on the temporomandibular joint, also known as TMJ. But here we're looking at the joint up close. We have synovial membranes, articular capsule, and an articular disc inside the joint. Okay, it's a small disc. Okay, and there are different movements of the temporomandibular joint. There can be lateral, side-to-side movement. Okay, let's now look at shoulder joint. So this would be the glenohumeral joint. It's the most freely movable joint in the body. Now, stability is sacrificed for freedom, okay, which means that its main movement is to, its main purpose is to move, and stability comes secondary. So it's a ball and socket joint. Let's see what we have here. So here's a picture of the glenohumeral joint. We've got the humerus. We can see the bursa, subacromial bursa, as well as this tendon sheath, which is also synovial membrane. So once again, I mean, there are a number of muscles and ligaments that hold this joint together, but flexibility is taken as the first priority and stability as the second priority. So stability is sacrificed for flexibility in the glenohumeral joint. Here's a cadaveric picture. Not too much here to see. Okay, so holding this joint together are four rotator cuff tendons: subscapularis, supraspinatus, infraspinatus, and teres minor. These are often torn, and you often hear about rotator cuff tears or rotator cuff rebuilds in surgery. So once again, the stability is sacrificed for mobility. Okay, just another look at this joint capsule. You can see various bursa, subacromial bursa, subscapular bursa, and a number of rotator cuff tendons attached. Another look here. We've got the glenoid cavity, glenohumeral ligaments, which stabilize this joint. Here's a cadaveric picture showing the head of the humerus, the acromion of the scapula. Okay, elbow joints. So the humerus articulates with the radius and the ulna. Remember, the radius is the one with your radial artery. So that's the one, that's the place where you take your pulse, and that's how you identify, or that's how I identify the radius versus the ulna. So there is an annular ligament that surrounds the head of the radius, as well as a couple ligaments that allow side-to-side movement. And so here we go with our elbow joints. We've got articular cartilage surrounding the joint, and this yellow stuff is the synovial cavity. Okay. And then we've got a bursa posterior to the trochlea of the humerus. Another look at the elbow joint. There are cross ligaments like the radial collateral ligament, the annular ligament that stabilize this joint. This joint is not as freely movable as the glenohumeral joint, and this joint is a lot more stable. Here's a cadaveric picture of it, and another picture just showing the system of ligaments that are attaching the bone to bone. Okay, hip. Hip is a ball and socket as well. It's large. Spherical head of the femur articulates with the acetabulum of the os coxae. You have 3 different bones that make up this acetabulum. Good range of motion, but the socket's very deep. So here is an example of the hip joint. We've got the femur, the head of the femur, acetabulum here, articular cartilage, of course, lining, and then you've got ligaments that cross the joint to give it stability. Okay, cadaveric picture showing the head of the femur, the acetabulum, or the acetabular labrum here, and various ligaments stabilize this joint. This joint is fairly stable. So you have the iliofemoral ligament and the ischiofemoral ligament, as well as the pubofemoral ligament. So we've got the pubis, the ischium, and the ilium. Those are what's going to make up the acetabulum that this ball articulates with. So for the hip joint, it's also coxal. That's what it's called. There are different ligaments like the iliofemoral, the pubofemoral, ischiofemoral, and then there's a ligamentum teres. Okay, the knee. This is actually the largest, most complex joint in the body, and it's because it takes so much stress. So the knee consists of a femoropatellar joint, which is a plain joint. It's got a lateral joint and a medial joint, all in one. So let's take a look. Okay, so we've got our femur that comes down, articulates with our tibia. This is the weight-bearing portion of the lower leg, and a number of ligaments that you might have heard of, like the anterior cruciate or the posterior cruciate. These are often injured in football or different sports when the knee makes a movement that is not what it's supposed to do, and these ligaments are torn and then surgically reattached. So here's another look at the medial meniscus, lateral meniscus, and the anterior cruciate ligament coming up, and the posterior cruciate coming from behind. These two stabilize this knee joint and keep it from, will restrict it to moving only in certain directions. So there are a number of bursa in the knee joint. There's, at least 12. So we won't go through those, but let's take a look at the patella. The patella is attached via tendons, the patellar ligament, as well as the quadricep tendon. There's also a medial patellar ligament, as well as a lateral patellar ligament called retinaculum. as well as a fibular collateral ligament coming from the fibula, and the tibia or tibial collateral ligament coming from the tibia. Okay, so the fibular and tibial collateral ligaments prevent rotation when the knee is extended. Oblique popliteal ligament stabilizes the posterior knee, and the arcuate popliteal ligament reinforces the joint capsule posteriorly. These are lesser known, kind of lesser torn ligaments. So here we've got a picture of these, the tibial collateral, arcuate popliteal, as well as fibular collateral and oblique popliteal. So quite a few ligaments that restrict the motion of this knee joint. Okay, so what keeps it from displacing anterior to posterior are the anterior cruciate ligament and the posterior cruciate ligament. So when there's a football injury and the knee is forced anterior lateral or posterior, these ligaments will become damaged because they stop hyperflexion and stop backward sliding. Just another picture showing the anterior and posterior cruciate ligaments. And a cadaveric one showing these same ligaments. So this is a posterior picture. You can't see the meniscus. I'm sorry. Okay, well, the patella has actually been deflected. So let's go on here. So there's a number of injuries that can occur. This one happens to be hockey. So it's called the unhappy triad, but it's showing how a hockey puck can force the knee joint to move medially, which disrupts a number of ligaments. Your anterior cruciate ligament, the medial meniscus will be torn, and the tibial collateral will be torn. And so this is the unhappy triad. It's quite common that with the anterior cruciate, you also tear the meniscus and the tibial collateral. So disorders of the joints, really a lot of this is tears due to compression, stress, and they're repaired with arthroscopic surgery. Okay, here is a picture of arthroscopic probe showing a tear in the meniscus, and they can repair this. Okay, sprains. So sprains are when the ligaments are stretched or torn. Common sites are the ankle, the knee, the lumbar region. These areas are poorly vascularized, so they repair very slowly. There's also dislocations, which are called luxations. When the bones are forced out of alignment, they will be accompanied with sprains and inflammation. There's also bursitis, which is inflammation of the bursa, usually caused by a blow or some kind of friction to upset this bursa. Tendinitis, inflammation of the tendon sheaths, as well as arthritis, which is a degenerative disease that damages the joints, like osteoarthritis, rheumatoid arthritis, or gout. So in osteoarthritis, it's irreversible, degenerative. It's caused by excess wear and tear where the articular cartilage is broken down, bone spurs develop. Osteoarthritis is more common in women than men. Okay, rheumatoid arthritis, this is an autoimmune disease where you have chronic inflammation. So the body is attacking its own cells. There's a lot of pain and swelling in rheumatoid arthritis. You can go through some of these, but the treatment would be immune suppressants to blunt the immune system so that it's not as powerful. Okay, there's gout. Okay, so deposition of uric acid crystals in the joints and soft tissue followed by inflammation, more common in men. It really affects the great toe a lot. And if left untreated, you will get fusion of bones, immobility. So then there's a kind of a miscellaneous disease, Lyme disease, caused by bacteria from ticks. The symptoms are like rash-like, flu-like symptoms, foggy thinking, but a lot of joint pain and arthritis. And Lyme disease, the treatment is a lot of antibiotics. Okay, that's joints in a nutshell. I'll see you Saturday.